Welcome back. Today we are really getting into the thick of it, strapping ourselves into that high-stakes exam chair. We're tackling the crucial decisions around total knee replacement surgery implants.
Exactly. This is all about getting you, the orthopedic resident, ready.
We want to distill years of, biomechanics, registry data, all of it, into something rapid, something you can use.
Yeah, actionable knowledge.
And first, let's be absolutely clear, this whole deep dive, everything we're discussing, it's based squarely on the fantastic OrthoMade Simple Notes. You can find them on the website mokyingren.sg.
That's right.
These notes were put together by Dr. Mok Ying Ren, who's a sports surgeon over at National University Hospital, Singapore. He completed his FRCS in orthopedic surgery from Edinburgh, so really solid stuff.
Absolutely. So our mission today, to help you build a really robust, comprehensive way of thinking about TKR components. We're synthesizing the pure biomechanics, the material science side, and this is key for your exam, the evidence from those big national joint registries, which, let's be honest, can often seem complex, even conflicting.
Okay, let's unpack this then, starting right at the beginning. What are we actually trying to achieve mechanically with the TKR? Fundamentally, it's about replicating normal knee kinematics, isn't it?
It is. And the cornerstone concept there is femoral rollback.
Define that for us quickly.
Sure. It's that essential posterior sliding movement of the femur on the tibia that happens as the knee bends, as it goes into flexion.
And why is that so critical?
Well, without it, you simply can't achieve a deep knee bend effectively. If the prosthesis blocks that rollback, you lose function. Plus, you run the risk of anterior impingement.
Okay, so if rollback is key, what does that mean for the design? How do you allow it?
It means the tibial surface, the part the femur moves on, has to be relatively flat, less conforming, you could say.
Which brings us straight to the posterior stabilized design, the PS knee. How does that ensure rollback happens? Does it rely on ligaments?
No, not really. That's the point. It doesn't rely on the PCL. It uses mechanics to force the rollback.
How?
There's a cam on the femur component and a post on the tibial component. As you flex, that femoral cam engages with the tibial post, and it physically pushes or cams the femur backward.
Got it. Mechanical enforcement. And thinking about knee movement, there's also the screw home mechanism, right? That little bit of external rotation of the tibia in the last few degrees of extension.
Yes, critical for locking the knee, for stability. And some designs, like the medial pivot knee, actively try to replicate that. They use asymmetric conformity to encourage that twisting motion.
But it sounds like even trying to replicate these natural movements leads to problems. You mentioned a compromise.
Yes, the condylar compromise. This is absolutely central. It's this constant balancing act, this trade-off between implant constraint, achieving those normal kinematics we want, and managing the contact stresses on the components.
Okay, I think I get the paradox, but state it again simply, maybe how you'd explain it in the exam.
Right. So for more normal kinematics, better function, basically you need lower implant constraint. Think a flatter tibial surface to allow that rollback.
Okay, lower constraint, better movement. Why is that a problem?
Because that flatter surface means the contact area between the femoral component and the tibial polyethylene liner is smaller. A smaller patch means higher pressure, higher contact stress on the poly.
And high stress means where?
Exactly. High stress equals a higher risk of polyethylene wear over time. So to reduce that stress and make the implant last longer, you have to increase a conformity, make the tibial surface cup the femur more.
But increasing conformity increases constraint.
Which takes you away from those normal kinematics.
Yeah.
It's this inherent tension. You're always trading off wear life against natural movement.
Okay, that clarifies the core challenge. Given that challenge, let's run through the spectrum of constraint options available. We have unicondylar at one end.
Then cruciate retaining, or CR.
Posterior stabilized, PS.
Then getting more constrained. Things like the LCCK, the legacy constrained condylar knee.
And finally, the most constrained, the rotating hinged knee.
That's the range.
So the big decision point often boils down to CR versus PS. If PS often makes balancing easier, why would you ever choose CR? What are the key exam points for retaining the PCL?
The main arguments for CR, the ones you need to know, are 1. Bone preservation. You avoid cutting the box for the PS post. 2. You theoretically preserve some proprioception because the PCL is still there providing feedback.
Makes sense.
And 3. You completely avoid any risks associated with the PS mechanism itself, like the post hitting the cam, this post-cam impingement, or more dramatically, the cam jumping over the post, which is cam jump.
Okay, those are strong points for CR, but the PS is often preferred.
For the exam, yes, you need to counter that. PS generally gives you a more congruent joint surface, meaning the parts fit together better. And crucially, it's often much easier to get the knee balanced intraoperatively, especially if the PCL isn't in great shape to begin with.
But you mentioned PS risks, cam jump, tibial post wear. Are those significant?
They are theoretical risks, and they do happen, though not commonly with modern designs. But it leads to an interesting alternative. The anterior stabilized, or AS knee. What's the deal there?
Tell me about AS.
Okay, so with AS, you still remove the PCL, just like in a PS knee. But the femoral component might look more like a CR one, no box cut needed. The stability comes with a polyethylene insert.
How?
It has a raised front lip, an anterior lip, which increases conformity and helps resist the femur sliding forward, the anterior translation.
Okay, so it stabilizes without the post and cam. Is there a downside?
There's a critical caveat, yes. That increased conformity, that snugger fit, means there's a larger surface area in contact. And the theory is more surface area could potentially mean more polyethylene wear debris generated over the long run, something to consider.
Right. Okay, jumping to the other extreme then.
Yeah.
When are CR or PS just not enough? When do you absolutely need the big guns like an LCCK or rotating hinge?
The indications are pretty clear-cut. You're looking at situations with global instability, maybe after major trauma, a bad fracture, or a deep infection that's destroyed the ligaments.
Or instability and extension.
Yes, or severe hyperextension instability. Think of someone with post-polio syndrome, for instance. Basically, cases where the patient's own soft tissues just can't provide stability anymore, and the implant has to do that job.
Okay, we've covered the movement goals, the constraint problem. Now let's look at the actual stuff we're putting in the materials and the shapes. Quick high-yield facts for materials.
Yep. Femur, cobalt chrome. Tibia, usually titanium, but sometimes cobalt chrome too. Patella component, typically titanium backing if it's modular, or all poly.
Let's focus on the femur design first. There's this idea of single versus multi-radius. What's that about?
Right, so older designs often had just one curve, the single radius. Multi-radius designs use two or sometimes more different radii of curvature, typically a larger one on the front part, the anterior part, and a smaller one on the back, the posterior part.
And the goal of that?
The theory, it helps optimize how the center of rotation moves as the knee bends. It's an attempt to better replicate that femoral rollback, especially when you get into deep reflection. It's all about improving the kinematics.
And the medial pivot knee takes that asymmetry idea even further, doesn't it?
It does. A medial pivot design deliberately makes the inner medial compartment highly conforming, a snug fit, while the outer lateral compartment is less conforming, flatter.
Why do that?
The idea is to make the medial side the main center of rotation. It's specifically trying to replicate that natural knee motion, including the screw-home mechanism we talked about earlier.
Interesting. Okay, moving down to the tibia again, but thinking about fixation. Stems. When do we need to add stems to the tibial component?
You use stems when you anticipate high stresses at the junction between the implant and the bone. This is especially true for those highly constrained implants, the LCCKs, the hinges.
Because they take more load.
Exactly. They transmit much larger forces and moments to the bone. The stem helps distribute that stress over a much larger surface area down into the tibial canal.
So the pros are better load distribution? What else?
They definitely resist shear forces better. They increase overall stability by reducing tiny movements, micromotion, at the implant-bone interface. And they can help prevent the tibial component from lifting off the bone, which is a form of instability.
Big advantages. But there must be downsides. What are the cons of stems we absolutely have to remember for exams?
Definitely. The big risks are, 1, stress shielding. The stem carries so much load that the bone around it might get less stimulus and potentially lose density, which could theoretically risk loosening or even fracture later. 2, you can get pain right at the end of the stem.
End of stem pain, right?
And 3, thinking ahead, stems make any future revision surgery much harder because they take up space and potentially compromise the bone stock you need for the next implant.
Good points. And just a quick word on the patella component design itself. It seems the all polyethylene ones are standard now.
Yes, largely. There was a period back in the 80s with metal-backed patellas that had pretty high failure rates, mostly due to wear of the thin poly. So the shift went to all polyethylene components. And the fixation has evolved too, moving from single large central pegs towards multiple smaller pegs for better distribution of fixation. Whether it's a symmetrical dome shape or an asymmetric anatomic shape is another variable.
Okay, a lot of detail there on components. Before we wade into the really dense evidence and registry data, just a quick reminder for everyone studying hard. This deep dive is grounded in the OrthoMate simple notes you can find on mokyingren.sg. Dr. Mok Ying Ren put these together, and they're designed to give you that strategic edge.
Absolutely. Now let's shift gears. We're heading into the evidence. For the exam hot seat, you need a clear stance backed by data on three really key decisions. CR versus PS we touched on, but also patellar resurfacing yes or no, and the type of bearing surface.
And this is where it gets complex, right? Bringing in trial data like KT, the knee arthroplasty trial, and those huge national registries like AOJ-NRR from Australia and the UK NJR.
Precisely. Let's tackle the bearing surface first. Fixed versus mobile bearing. What's the generally accepted, safer stance for your exam right now, and what's the evidence?
Okay, fixed versus mobile. What should I say?
The standard, well-supported stance is definitely in favor of fixed-bearing TKR, preferably one with higher articular congruity. The evidence backing this up is pretty strong, especially from the Australian registry.
The AOJ-NRR, what does it show?
It shows significantly lower revision rates for fixed bearings compared to mobile bearings. We're talking 8.3% versus 9.5% revision at 15 years, I believe. That's a noticeable difference in a huge data set.
What about trial data? Didn't the KT trial look at this?
It did. And interestingly, KT showed no real difference in functional outcomes between fixed and mobile. But here's a key point for exams. When large registry survival data conflicts with functional outcomes from a trial, the survival data, the revision rate, often carries more weight in establishing the standard of care. Lower revision rate usually wins.
Okay, fixed bearing is the default. Now, this is where I think it gets really complex. The polyethylene choice. Standard UHMWPE versus the highly cross-linked stuff, HXLPE. Historically, what was the thinking?
Yeah, this is a hot topic. Historically, the common resident stance, based on biomechanics, favored normal PE, the standard ultra-high molecular weight polyethylene.
Why?
Because the knee articulation is often described as round on flat. It's not like the hip where you have a very conforming ball in a socket. In the knee, the contact area is smaller, more concentrated. The concern was that HXLTE, while great for wear in the hip, might be more brittle and potentially prone to fracture or catastrophic failure under the high contact stresses seen in the knee's less conforming design.
Okay, that was the theory. But what's happening in practice now?
Well, that theory is running headlong into current practice trends and registry data. You absolutely have to acknowledge the increasing popularity of HXLPE. In the AOJ-NRR now, it's used in well over 60% of TKRs.
Wow, over 60%. And does the Australian data support that switch? Does HXLPE show better survival there?
It does. The AOJ-NRR data actually shows better revision rates for HXLPE compared to standard PE, something like 4.9% versus 7.8% at 10 years, I think. That registry data is hard to ignore.
Okay, so Australia suggests HXLPE is better, but isn't there conflicting data from the UK?
Exactly. This is the nuance you need. You have to reconcile the AOJ-NRR findings with the big UK NJR study published by Thomas Partridge and colleagues in 2020. They looked at 12-year data.
Then what did they find?
They found virtually no difference in the overall revision rates at 12 years between the highly cross-linked poly and the conventional poly.
No difference overall. So that would suggest maybe the extra cost of HXLPE isn't justified for everyone.
That's the implication for the general population, yes. And this is crucial for your exam answer. The UK study did find that HXLPE performed better, had better survival, specifically in certain high-risk subgroups.
Which groups?
Patients under 60 years old, patients with a high BMI over 35, and interestingly, patients who received the newer second-generation, highly cross-linked poly.
Ah, so it's not just HXLPE, but maybe the type of HXLPE matters?
It seems so. So the conclusion you need to articulate is nuanced. Standard PE remains acceptable, it's got a long track record, but you must show awareness that HXLPE, especially newer formulations, is showing compelling benefits in these specific higher-risk groups, even if the overall 12-year data doesn't mandate its universal use just yet. Cost versus benefit is still a discussion point.
Okay, that's a complex picture, but a clear way to frame it. Let's switch to patellar resurfacing. Yes or no? What's the traditional resident stance?
The classic position has generally been selective resurfacing, meaning you only resurface the patella in specific cases like severe arthritis on the back of the kneecap or perhaps in patients with rheumatoid arthritis where the bone quality might be poorer.
And what did the trials say about that?
Again, we see some conflict. The KC trial, and also a big meta-analysis back in 2012 by Pilling et al. In JBJS, they both found essentially no difference in functional scores or in rates of anterior knee pain whether you resurfaced the patella or left it alone.
So trials suggest it doesn't matter much for outcomes.
For those specific outcomes, yes. However, the Australian registry, the AOJ-NRR, throws a wrench in the works again.
How so?
The AOJ-NRR data found a statistically lower overall rate of revision for any reason in knees where the patella was resurfaced compared to those where it wasn't.
Lower revision if you do resurface. That pushes the argument the other way, towards routine resurfacing maybe.
It certainly strengthens that argument, yes.
Yeah.
The registry data suggests it's a viable benefit.
Hmm.
So if you do decide to resurface, based perhaps on that registry data or surgeon preference, what are the technical points you must mention?
Good question. What are the key technical tips?
Two main things. One, make sure you don't take too much bone off the patella. The remaining bone thickness after you cut it should not be less than about 12 millimeters. Keep it substantial.
Okay, preserve bone stock. What's two?
Two, position the patellar button correctly. It should generally be placed slightly medialized towards the inner side on the cut surface. This helps ensure proper tracking and reduces the risk of instability or dislocation later.
Got it. Thickness and medialization. Okay, one last big decision point. Cementation. What's the definitive stance here? Cemented or uncemented TKR?
For TKR, based on current evidence, the stance is non-negotiable for exams. Cemented TKR.
And the evidence.
Again, the AOJ-NRR provides very clear support. It shows substantially lower revision rates for cemented TKRs compared to uncemented ones, looking out as far as 18 years. The difference was something like 7% revision for cemented versus 10% for uncemented. Cement wins on longevity.
Okay, cemented TKR. What about for a unicondylar knee, arthroplasty, a UKA or partial knee? Same applies.
For UKA, the discussion is a bit different, often focused on fixed versus mobile bearing within the UKA implant itself. The general stance, often influenced by specific implant systems like the Oxford mobile bearing or fixed designs like the Zimmer ZUK, leans towards fixed bearing for many surgeons.
Why fixed for UKA?
Often it comes down to surgeon training and familiarity, and arguably a lower risk of one specific complication bearing dislocation, which can happen with mobile bearings if not perfectly balanced. The AOJ-NRR data for UKA actually shows no significant difference in revision rates between fixed and mobile bearing UK designs overall. So fixed is often chosen for simplicity and potentially lower risk of that specific complication.
Right, that makes sense. So summing this all up, it feels like the core challenge in TKR implant choice is really navigating this tension, isn't it? Between the established proven standards like cemented fixation, maybe fixed bearings, and then the newer evolving stuff like HXLPE.
That's exactly it. And it forces you, the resident, to critically appraise the evidence, especially when the big registries seem to show slightly different things or evolve over time.
So the biggest takeaway for someone listening, preparing for their exams, isn't just memorizing implant X is best.
No, absolutely not. It's understanding the why. Why does the biomechanics lead to certain design compromises? How do those designs then perform in the real world, according to registry data? And where are the current controversies or areas where the evidence is still unfolding? That's the level of understanding needed.
Okay, so let's leave our listeners with a final thought to chew on. Given what you said about XLP, especially the newer generation stuff showing promise in those high-risk groups,
Yes.
how much longer can the standard practice really rely heavily on that older, say, 15-year data that might favor conventional poly when these newer materials are showing increasingly good short to medium-term results, particularly for younger, more active, or heavier patients? Is a shift towards HXLPE becoming inevitable?
That's the provocative question, isn't it? How long does it take for compelling medium-term data on newer materials in specific groups to potentially shift the overall standard of care? That gap between the long-term data we have on old materials and the emerging data on new ones, that's the space to watch.
A fascinating points to consider. Well, this deep dive, packed with foundational knowledge and that crucial evidence-based decision-making for your exams, was based entirely on the Ortho Made Simple notes from mokyingren.sg. We really hope it helps you solidify your understanding.
We wish you all the best in your preparation.
And as always, we end with a blessing and some encouragement from God, taken from the book of Proverbs. The wicked are overthrown and are no more, but the house of the righteous will stand. Proverbs 12.7.